Page 119 is where we're going to pick up here. We're going to talk about antibiotic side effects that are not allergy. And if we're going to lament all of the excess antibiotic prescribing, which we do at length here for upper respiratory infections and sinusitis and such that don't need them, for asymptomatic bacteriuria and things like that that don't need them, in small kids that don't really have urinary tract infections that don't need them. If we're going to lament all that, one of the things we should become pretty expert at is recognizing things that the antibiotics have done that are really a pretty important adverse event, and recognizing that the antibiotics are the cause. When I worked at LA County, which is sort of an indigent, immigrant, underserved, access-deprived population, I didn't see people on dozens of medications. You know, they came in, it wasn't uncommon to be the second doctor they'd seen in their whole life. At Stony Brook, it's just the opposite. Everyone has many doctors, and it seems like for each doctor they see, they're on 3 medications chronically. I see 25-year-olds that are on 20 medications. I look at their drug list, and I'm like, who thinks you need to be on 20 medicines chronically? I'm not talking about short courses. They're on 20 medications. It's like, oh my God. I mean, I started thinking about the toxic soup that they're ingesting. I don't even know how they keep it straight. I mean, I'm talking about relatively young, healthy people who swear they have diseases they don't have. And it's just like, wow, it's hard for me to wrap my head around. But this chapter is going to focus in on these non-allergic antibiotic side effects, some of which are important, some of which are less important, but we're going to go through. Let's, on the last page, if you will, where there's that blank space, let's make a list of, I have 17 of these side effects. We're not going to talk about all of them. Some of them you know from other things. The first one is antibiotics that increase your coronary artery disease risk. We'll talk about that. Antibiotics that cause hyperkalemia. Antibiotics that screw up your anticoagulation status, particularly if you're on warfarin. Antibiotics that cause hypoglycemia. Antibiotics that cause altered mental status and antibiomania, delirium. Antibiotics that cause new or provoked or worsened neurologic disease, peripheral neuropathy, myasthenia gravis. Antibiotics that cause erythema nodosum. Antibiotics associated with DRESS, which is drug-related eosinophilic syndrome. Stevens-Johnson syndrome. QT prolongation. Substantial myelosuppression. Antibiotics that result in them getting much, much worse infections. Extended spectrum beta-lactamase resistance infections and C. diff. Antibiotics that result in headaches. Antibiotics that result in unwanted pregnancy. Diarrhea we know about, drug-induced hepatitis, and red man syndrome. So that's a list of 17 substantial side effects of antibiotics that are not allergy related. Even the eosinophilic syndrome one is not purely an allergy thing. It's immune, but not listed under allergy. So we're going to go through some, but not all of these, and I'll get back to that list, and we'll sort of fill in the blanks as to when should we be thinking about it. So the first 6 papers here, and the 6th one is a naysayer, but 1 through 5, all offer up this idea that came out maybe almost 20 years ago. There was a time when if you suggested that peptic ulcer disease was infectious, you'd have been laughed out of town. And in fact, the original researcher that suggested that was not only laughed out of town, he was ridiculed by his colleagues, ridiculed by infectious disease experts, ridiculed by the gastrointestinal community, and ultimately we found out that, you know what, that H. pylori thing is actually pretty real. Around that time, there were some people suggesting that coronary artery disease might have an infectious component. That people who had upper respiratory tract infections and elevated CRPs and elevated nonspecific infectious markers often had heart attacks around that time. And so people started looking into this. I think the idea that coronary artery disease is infectious is wrong. I think that's where we're at. But is there an association for these people when they're placed on antibiotics with bad cardiovascular outcomes? Yes, there is. It's a small absolute increase in risk, and we got some papers. So abstract 1, a meta-analysis of 2 million usages of azithromycin, and what they found was that particularly in elderly people with background coronary artery disease, that the risk of having an important dysrhythmic event or a sudden cardiac event were increased with a hazard ratio of almost double the risk. Now, the absolute risk is low in that group, right? Maybe it's, even though they have coronary artery disease, if you're looking at them, you know, what's their risk in the next 2 weeks, you know, it might only be 1%. So if you doubled it, it would go up to 2%. But it was kind of looked at. And then abstract 2 looked at all-cause mortality and cardiovascular deaths from all the VA records from 1999 to 2012. And they compared those that got azithromycin and levofloxacin with those that got amoxicillin. So they didn't compare antibiotics with no antibiotics. They compared known problematic antibiotics with amoxicillin, not a problematic antibiotic. And what they found was that compared to amoxicillin, if you were on one of the other ones, you had a 1.5 rate increase in death overall, and you had an almost 2-fold doubling of serious dysrhythmias, VTAC, VFib, those types of things, even an AFib with rapid ventricular response. And so we know that these drugs are QT prolongers. So if you take an older person, you know, you picture an older VA person, maybe they got COPD, they're on a beta agonist already, they're on an inhaler, they have cor pulmonale, they have known coronary vascular disease, they're hypertensive, they're not that compliant with some of those meds. Now you put them on azithromycin with a half-life of 96 hours, that's a QT prolonger. Maybe they're a drinker, a little bit hypokalemic, a little hypomagnesemic, things that increase your risk for QT prolongation. And I don't find that result very surprising at all. If you took that population and put them on a QT prolonging drug, you might be rewarded with an admission for an episode of VTAC or an episode of an acute coronary event. Now, why might you get the acute coronary event? I think the QT prolongation is self-explanatory, but when you have an infection, an upper respiratory infection, and your CRP is up and your ESR is up, why do we think that might provoke coronary artery disease and MI? So that, independent of other things, this is back to the infectious thing, is that when you have these inflammatory processes going on, you probably destabilize plaque. So you have an array of plaque in your coronary artery disease. Some are hard plaque, some are soft plaque, some are near occluding, partially occluding. And we know that the long-term hard plaque that gives you greater occlusion isn't usually what causes your MI. It's a soft plaque that ruptures, you get a platelet plug, then you get acute ischemia. And we know that inflammatory processes may destabilize these plaques. So now we're looking at both the concept that you got an inflammatory condition, your plaques might not be that stable. That's one of the reasons we talk about giving double doses of statins in the acute MI setting, because it's a plaque stabilizing, endothelial function stabilizing item. That's why some people give a double dose of statins to their MIs that are going to the lab and things. It takes a little while to set up, but particularly in an NSTEMI that might be going to the cath lab tomorrow or the next day, there's a fair amount of evidence suggesting you might give that person a double dose of statins because it's anti-inflammatory and plaque stabilizing. So upper respiratory infections are the opposite of that. They're inflammatory and plaque destabilizing. And so the idea that this infection, then you add a QT prolonger to it, you might get somewhere with that. That's not good. Abstract 3 talks about the small increased risk and says that the QT prolongation results in dysrhythmia and the inflammatory state may result in plaque instability. 4 is from Vanderbilt, 5 is from Italy. They all say the same thing, that there's a small but absolute increase in risk. Maybe the hazard ratio or odds ratio doubles in that order, 1.5 to 2-fold increase of a low baseline rate for any given time. And the temporal association of these events with their antibiotics is pretty clear in these papers. Abstract 6 says, we're not so sure about it. But I think the overwhelming data is that there is, in fact, an association in an older patient population that's vulnerable, that might have some of the things I've talked about, known coronary artery disease or existing coronary artery disease. They might have other comorbidities like hypertension and such, that when they have an acute respiratory tract infection and placed on azithromycin or a fluoroquinolone, that they're in a little bit of a dicey state for the next 2 to 3 weeks in terms of their risk for a cardiovascular event. All right, 7, I think, is a super important paper. And when I worked at LA County with a younger patient population, I just didn't see this, or if I did, I didn't recognize it. But in the 16 months since I've been at Stony Brook, I am seeing all kinds of this, of what's talked about in 7. So in 7, they talk about the neurologic issues with quinolones. And if you talk to people, anyone here taken a quinolone and all the drugs that have the quin in them do some stuff to your sleep and your dream cycle. That's when we talk about mefloquine for malaria. I love me some mefloquine. When I'm taking mefloquine, when I'm traveling, on the second day, right, it's weekly when you take it, right? And this is the drug that they said, causes some people to have psychotic. We had a resident absolutely lose it in Ghana one year. We had to chain him to a radiator. I'm not kidding. We had to chain him to a radiator and fly him out. 2 days later, he totally lost his shit on mefloquine and was going to get killed on campus. It was like, holy crap. He was screaming at the faculty, fuck me up the ass, fuck that. I'm not making it up. We're like, oh yeah, we will. Chain him to the radiator. We were worried he was going to get killed. But that's with mefloquine. When I take mefloquine, they talk about, do you get vivid? I don't get depressed or anything, but the dreams. The second night of mefloquine for me, or the second or third night, people are like, oh, we're going out for a few drinks. I'm like, no can do. They're like, why? Oh, I'm starring in a full-length feature about an hour after I go to sleep. And in that full-length feature, it will be me, but I will be somewhere between James Bond and David Beckham. I still have soccer dreams. When I'm on mefloquine, I have these soccer dreams to music. I'm on a perfect field. It's lit at night. I'm shredding the defense. There's music. It's awesome. It's awesome. I can't wait to go to sleep on the second. And if you talk to people who are on Plaquenil for lupus, mefloquine for malaria prophylaxis, the fluoroquinolones, you get that quin group in there and it starts messing with some neuro stuff. And some people just get vivid dreams like me and like it, and some people get a whole bunch of much less pleasant things. Some people will lose it and get delirious. But if you talk to people, if you just start asking people who are finishing a dose of fluoroquinolones, just ask, how was your sleep? They'll tell you, oh no, just couldn't, or loved it, or whatever, you'll get this thing. But there are a whole bunch of other things. So seizures, threshold goes down. So new onset seizures on fluoroquinolones, confusion, myoclonus, peripheral neuropathy increases, this weird vertex headache syndrome you'll see people coming in with, and you stop their quinolones and all this stuff goes away. And then finally, remember there are now 3 black boxes on fluoroquinolones. There's a lot of pressure on us to stop using them. The 3 black boxes you're well familiar with. One is the tendinopathy and the cartilage problems, right? 2 is the altered mental status, dementia, delirium, peripheral neuropathy, and 3 is the QT prolongation. So anytime you're thinking of writing for a fluoroquinolone, you better ask yourself, is there something else that might be better? There are 3 black boxes, and there has been not that the legal activity is the reason to change your practice. I think just being aware of what the problems with the drug are and that it has a lower safety profile than we were originally sort of set out to believe is worth knowing. And if you're seeing an older population that might have some sundowning potential and stuff like that, you see someone, this is pretty typical at Stony Brook. You see someone who comes in from an extended care facility. They're still independent, but they have they're in one of those kinds of places. And they might have some, baseline Parkinson's or Alzheimer's, but they're still doing pretty well. And they have some other, medical problems. Maybe they're on a sedative at night or something like that, or some trazodone or something. This is not the kind of person you want to put on a fluoroquinolone for their urinary tract infection that they don't really have, because the result may not be so pretty. So this paper, they even talk about, and patients are now beginning to know it. Have you had a patient coming in and say, I'm floxing? I have. So they call it fluoroquinolone toxicity syndrome. If you look it up on the internet, you'll find all kinds of patient reports about their floxing syndrome, which is this mix of these neurologic, delirium, myoclonus, sleep disturbances, headaches, plus minus the tendinopathy. So this is out there in the lay press, and it's there for you. The tendinopathy, although we don't have papers in this chapter on it, there are many in the database. The tendinopathy thing is pretty amazing, right? It's mostly men. It's usually age greater than 60. It's almost all the Achilles tendon. Sometimes it's bilateral. they'll rupture them both, because when the first one pops, they go to catch themselves with full weight on the second one, then the second one goes and they crumple. How long after a dose of Oflox or Levoflox are you at risk for a tendon rupture? So up to a year. Some papers have it extending out 2 years. But certainly your risk is increased for the next 3 to 6 months, for certain. When they say this stuff penetrates tendon and bone, which is why the orthopods originally loved it. Remember, the orthopods loved the fluoroquinolones when they came out, because they penetrate tendon and bone and they cover Pseudomonas, which was one of their chronic infection problems in the orthopedic world. They love the quinolones. Yeah, no, this shit really penetrates tendon and bone. It so penetrates it that you're at risk for a tendon rupture for 6 months afterwards. Yes?
How much is the supraophthalmic absorbed?
So we don't know that much about it. So the question here is, do the eye drops do it? So I'm glad you mentioned this, because eye drop toxicity is a real deal, right? So people put on the timolol for their chronic open-angle glaucoma with worsening CHF and blocks. Well known that the timolol absorption results in systemic side effects that are important. I haven't seen anything that documents the fluoroquinolone eye drops doing the same thing, so I can't answer, or the eardrops. We know the eardrops can cause ototoxicity, particularly in someone with a ruptured TM. They are ototoxic, and the more so if you have a ruptured TM. But I don't know about systemic symptoms beyond the eye or the ear. I'm not saying they do or they don't, I just don't know. So these neurologic things, if you look for them, you'll find them. You'll find people, and it's often their decompensation is often credited to their disease. You see a person, they've maybe got a little small pneumonia, they're put on levofloxacin, a respiratory fluoroquinolone, then they're decompensating, sundowning, delirious in the hospital, and people think, they're hypoxic, they're old, it's just their disease. No, it's the fluoroquinolone. It's the fluoroquinolone that's pushing them over the edge and causing all of this stuff, resulting in them being restrained and all these other things that are happening to them in the hospital that are just, when you think about it, how would you like to be an old person who's a little bit frail? You get put on an antibiotic that causes you to totally lose your shit. That's not good. That's not a good thing to have happen to you, right? Your length of stay is going to go up dramatically, restrained in some telemetry unit. Just the thought of it is frightening to me. So all of these, and please be aware about the myasthenia gravis thing. So I've seen now 2 cases of Stony Brook of young, healthy women, no history of myasthenia gravis, finishing treatment for pyelo. They were placed on a fluoroquinolone, who now have neuro symptoms where they turned out to have myasthenia gravis. Where it seemed to me, and you don't want to kind of get in the middle of sort of inserting something you're not sure of, but I had strong suspicions that the fluoroquinolone provoked. Now, would they have gotten myasthenia gravis in another 3 years if they hadn't had this provocation? I don't know. Who knows? That's part of the reason you don't mention it. But while I was caring for them, I was thinking, fluoroquinolone, not so good for you. I don't know what the relationship is here. I don't know if it's causal, but the timing is certainly suspicious of just completing a course of a fluoroquinolone, now have myasthenia gravis. So, yeah.
Yeah, some of the neurologic features or risks, are they also delayed as well?
No, so they don't last as long. So that we do have an answer to. The question was, we mentioned that the tendinopathy you're at risk for 6 months out. Because of the penetration of bone and tendon of these drugs and their unique properties to get into that connective tissue. That's not true with the neurologic stuff. It seems much more related to serum levels. In the cases where they figured it out and someone got admitted for antibiomania, they find that withdrawal of the drug usually results in resolution of the neurologic stuff within 3 to 5 days, usually at the 3-day side. So no, not the persistence of that. Again, because so many of these patients have diabetes or other comorbidities, it's hard to know, but yes, some of it resolves relatively quickly. But if they have diabetes, maybe it's going to persist. All right, then we get to abstract 9, and there's, this is no surprise to anyone that if someone's on warfarin and you put them on a drug that impacts the metabolism of warfarin, the drug-drug interaction with a worsening of their anticoagulation status, and bleeding is a well-known risk. And there are a lot of drugs that do it. Abstract 10 goes through the high-risk drugs. The 4 highest-risk drugs are Bactrim, Cipro and Levo, Flagyl, and fluconazole. Those are the 4 highest-risk ones for resulting in your INR going from 1.9 to 7. And some of them, they don't always bleed, but some of them bleed. And 11 is a meta-analysis of this that, I don't think is that important. This side effect is really well known. What we don't know is, say the person has a pretty clear-cut MRSA infection and they're on warfarin and you want to put them on Bactrim, what should you do? Should you tell them to decrease their anticoagulation dose in half or alternate days? I've done both of these things on occasion for them. The official recommendations is just to test them frequently during the course of the antibiotic. But and it also depends on why they're anticoagulated, right? So if they're anticoagulated for a valve, a mechanical valve, where becoming unanticoagulated might result in the valve clotting off, then I don't tell them to back off their doses. If they're anticoagulated for a fib, where the annual risk is 0.3%, even with their anticoagulation, I feel more free to tell them to alternate days or half their dose kind of thing. So you got to find out why they're anticoagulated as part of the formulation of your response if you're going to put them on, Bactrim, for example, for an MRSA infection. So double the risk in abstract 10, it's double the risk of hospitalization and bleeding, odds ratio 2.1 if you're placed on one of these antibiotics, particularly Bactrim, while you're on Coumadin. So that's pretty important. That's pretty important. Yes? So it's not purely one or the other. A lot of it does have to do with liver metabolism. It's not just it's not just gut flora. And that's why the fluconazole is in the list, right? We know that azoles really impair liver function more than others. So in that one in particular, it's much more about liver function than gut flora. Some of the others are a mixed effect. So yeah, no, we don't know. We do know that some antibiotics are much worse in terms of cleaning out your gut flora, and I'm going to talk about that. Why don't I take it now? I had a friend going to the southern Sudan to do some relief work, and I got my DTMH at the Gorga School of Tropical Medicine in Peru, and I asked him what was he doing about malaria, and I said, do you want me to write you a script for Malarone? And he said, no, I'm just going to take Doxy, and I said to him, not a good idea. One, Doxy prophylaxis is not that good for malaria, and two, Doxy is notorious for wiping out all the good guys in your GI tract, this gut flora issue. And he was like, he was stubborn, and he went ahead and did it. And he went there for 3 weeks, and he came back, and shortly after he got back, he got a fever, and it was determined that it might be urinary infection, and by himself, he had some urinary symptoms, so he self-treated, I think with Keflex or something like that, and it didn't get better. And 5 days after that, he was in the ICU, hypotensive, with extended spectrum beta-lactamase resistant UTI and urosepsis. Almost killed him. So the choice of doxycycline didn't go so well. I resisted all urges, and you can imagine how hard this was for someone as spiteful as myself, to say, I told you so. And the same is true with things like Clinda. We know that Clinda is a really big provoker of C. diff infection and pseudomembranous colitis. So you do got to pay attention to these flora things. I don't know if the probiotics help, things like Activia and these other tablets, but I often tell people if they're taking these things to try and do themselves some favor and have some Activia every morning to try at least get some lactobacillus friendlies down there while they're wiping out all the friendlies on the E. coli side. All right, how about with diabetics? Is there problems with hypoglycemia? Well, it turns out that the sulfa drugs are sort of like the sulfonylurea anti-diabetic agents, and they make the same sort of receptor-based thing. And so Bactrim associated with hypoglycemia, pretty well documented. Abstract 12 says the odds ratio of getting a hypoglycemic event if you're placed on Bactrim is 6 times higher. Should think about that. It's not just Bactrim. Abstract 13 says it's Flagyl and Cipro as well. Number needed to harm, and this puts it in perspective. Is it a huge risk? The number needed to harm in that paper is 70 to 300, depending on the antibiotic. But we know that these antibiotics potentiate that receptor-based response and can cause some hypokalemia, some hypoglycemia. How about hyperkalemia? Again, we're talking about Bactrim. You place a 60-year-old on Bactrim who's got a little bit of baseline renal insufficiency. Maybe they're on an ACE inhibitor as well, or spironolactone as well. People who are already on an ACE inhibitor or an ARB and or spironolactone, when you put them on Bactrim, you better watch what's happening with their K. Lots of papers here talking about this. Abstract 14, median age 66. Maximum potassium happened around 10 to 12 days into the course. So the potassium rises gradually while they're on the antibiotic and they're maintaining their ARB or their ACE or their spironolactone. Abstract 15 also says it happens in oldsters. The odds risk of hyperkalemia, if you were on TMP sulfa with a spironolactone in abstract 15, odds ratio of getting a hyperkalemic event, 12. That's a high odds ratio. That means it's really substantially more likely that you're going to have this issue. Abstract 16 says, yeah, and sometimes they die of it. It's a nice clean kill. Spironolactone, a little ARB, a little Bactrim, culled from the herd of a hyperkalemic death, sudden death. Odds ratio 1.5 with Cipro, 2.4 with 2.5 with TMP sulfa, and so this hyperkalemic side effect in patients who are on an ARB or a spironolactone or an ACE inhibitor is something you probably ought to be aware of. Ought to be aware of. This means that when you're going to send one of these patients out on Bactrim for their MRSA infection of their finger or something like that, that they need to be followed. They need to have close follow-up by their PMD, who might check a K. Or my favorite is you send them to their PMD, who does what with them? Day 3, you say, I think you should have close follow-up with your PMD. Go get checked because we're worried we want to follow. The PMD goes, what's wrong with those people in the ER? I can't check a K here. Go to the emergency room. So then they're pissed off. So now they're back to you again so that you can check the potassium because the PMD doesn't have a way to check the potassium in the office and they want you to get it checked. All right, and then abstract 17, one of the last in this group, talks about wrongful life. There's been one suit for wrongful life in the state of California where a girl who was on birth control pills, low-dose Overall, the 777, was placed on rifampin and claimed she was compliant and she got pregnant. She said it was the rifampin that did it. And this paper says this whole idea that antibiotics decrease the efficacy of the birth control pill is largely a myth. It doesn't happen with things like Keflex and other drugs like that. The only drug that really impacts the efficacy of the pill is rifampin. This patient was placed on rifampin that sued for wrongful life. And we're seeing some people, why would someone be placed on rifampin nowadays, aside from tuberculosis? Yeah, so they got recurrent colonization with MRSA in their nose and someone wants to decolonize them, rifampin is the way you go about that. And the other reason is somebody gets meningitis, and so the prophylaxis, I mean, there's a tsunami for every case of meningitis, all the people who want prophylaxis for it is, which is not true, right? You need to have direct respiratory exposure to them. Invariably, when you have a case of meningitis like that in the emergency room, like 30 people go get prophylaxis, when really maybe one warranted prophylaxis. And then finally, just talking about antibiotic diarrhea is 18. Augmentin is a guaranteed diarrhea. 22% of the patients here got some. This is a study out of University of Massachusetts that talked about this. It said that 5 to 39% of anyone on any antibiotic will get diarrhea because of their gut flora changes, and that of those that got diarrhea, somewhere between 1 in 5 and 1 in 20 will be C. diff. So that's it's of the diarrheas, that's the number that are C. diff, but it's pretty important. And more prevalent with IV antibiotics. I found this surprising. I thought it would be more prevalent with PO antibiotics, but it was more prevalent with IV antibiotics. And the lowest rate of diarrhea inducing in these was interesting. It was the quinolones and the doxy. How long did they get diarrhea for when they had antibiotic-induced diarrhea? It's not trivial. Average duration of their diarrheal symptoms after they got an antibiotic-induced diarrhea was 9 days. That'll make you forget about your otitis media. Your ass will hurt so much more than your ear after you scrape off all the mucous membrane around it from wiping your ass constantly. Suddenly the ear pain will seem like nothing. It's the cure. So there's a list for you, and I really think that the neurologic stuff is something that's not well known and ought to be paid attention to. And I hope you'll take a look at this. I think it's kind of an interesting list. The hypoglycemia and hyperkalemia things are also not that well known or remembered and are certainly worth having an ear and an eye to in the future. Thanks. Jan, you're up.